Sepsis is the commonest cause of neonatal mortality and is responsible for 30 to 50% of the total neonatal deaths each year in developing countries. It is estimated that 20% of all neonates will develop sepsis and approximately 1% die of sepsis-related causes. Sepsis-related mortality is largely preventable with rational antimicrobial therapy and aggressive supportive care. The objectives of the study were to establish the clinical and laboratory profile, the antimicrobial treatment response, and the occurrence of complications and outcome. Inclusion criteria was all cases of NICU admitted neonates with positive blood culture whose parents given oral or written consent to be included in the study. Any cases of NICU admitted neonates with sterile blood culture or any cases whose parents did not give consent were excluded from the study. It was a health facility based cross-sectional analytical study which was conducted between October 2020 and March 2021. 123 babies were included in the study which fulfilled the inclusion criteria. Detailed information was extracted from the case file regarding the basic data, demographic data, maternal risk factors, gestation age, clinical features at presentation, lab reports, treatment course response, any complications and interventions, and outcome. The data was analyzed by Tableau software. Coming to the results in month-wise distribution, the maximum number of sepsis cases were reported in the month of March 2021, which was 33.3% cases. 75.6% of the cases were delivered in a government setup. The maximum number of cases were of normal weight, that is 50.4% cases, followed by low birth weight, which is 36.6% cases. 65.1% cases were outborn. In the gestation age by weeks, maximum cases were of 37 to 38 weeks gestation, that is 23.6% of the cases, followed by 36 to 37 week gestation, that is 18.7% of the cases, followed by 38 to 39 weeks gestation, which is 12.2% of the cases. 49.6% of the cases were preterm, 50.4% cases were term, and there were no post-term cases in the study. In coming to maternal risk factors, 79 cases, that is 64.2% cases had no risk factors. 11.3% cases had oligohydramnios in second or third trimester. 10.5% cases had PROM for more than 24 hours. 6.4% cases had hypothyroidism and 3.2% had hypertensive disorder of pregnancy, including eclampsia and preeclampsia. Coming to reasons for referral or admission, in 50.4% cases it was respiratory distress. In 18.6% cases was dull activity associated with decreased feeding. 76.4% of the cases at admission and 85.4% cases after admission showed clinical symptoms or signs of sepsis. But the initial sepsis screening which was done in the hospital, only 64.2% cases showed positivity. 73.2% cases were early onset sepsis and 26.8% cases were late onset sepsis. Coming to the blood culture isolate, 44.7% cases were Klebsiella, 19.5% cases were Citrobacter, and 9.7% cases were Staphylococcus. Other organisms cultured were Pseudomonas, Acinetobacter, Candida, Salmonella, and E. coli. Coming to sensitivity reporting, 33.3% cases showed sensitivity to ampicillin, 34.1% to piptaz, 1.6% to amikacin. Maximum sensitivity was to meropenem, that is 69.9%. Coming to resistance, 6.5% cases resistant to ampicillin, 11.3% to piptaz, 1.6% to amikacin, and maximum resistance was to cefepime, that is 25.2%. CSF analysis was not done in 30.1% of the cases. 6 cases showed abnormal CSF pattern, that was meningitis. Antibiotics were started on first day of admission in 80.5% of the cases, on day 4 after culture sensitivity reporting in 13% of the cases. First line antibiotic of the unit policy is to start ampicillin amikacin in 81.3% of the cases, followed by 11.4% cases were started on piptaz amikacin and 3.3% cases on cefotaxime amikacin. Second line shift was done in 28.5% of the cases. The reason for which being maximum cases in 48.5% in view of sensitivity reporting, 45.7% cases in view of no clinical response, and 8.5% cases in view of abnormal CSF analysis. Coming to complications, 13% cases showed hypoglycemia, in which 37.5% cases required GIR, 6.5% cases had apnea, in which 75% cases required caffeine, 8.9% cases showed seizures, in which 90.9% cases required phenobarbital, and others were given levetiracetam and phenytoin. DIC was there in 4.9% of the cases. Inotrope support was required in 24.4% of the cases. Out of all cases got dopamine, 10% cases adrenaline, and 6.7% cases dobutamine. CPAP was given in 26% of the cases, and ventilator support was given in 26.8% of the cases. Transfusion was needed in 8.1% of the cases, and maximum cases, that is 60% cases, were requiring FFP for DIC. Weight at outcome, Maximum cases, that is 46.4% cases, showed a decrease in weighted outcome, increase in weight in 14.6 and same weight in 39%. In outcome, 65% cases were discharged, 20.3% cases died, and 10.6% cases went lama, which were the maximum outcomes. In duration of stay, maximum cases stayed for more than 14 days, that is 50.4% of the cases. Coming to discussion, most cases showed clinical improvement with ampicillin and amikacin combination despite resistance in in vitro culture reporting. 76.4% cases on admission and 85.4% cases after admission showed clinical signs and symptoms of sepsis, whereas the initial sepsis skin was positive only in 64.2% of the cases. The most probable reason for this could be the most cases referred to the institute have already received antibiotics prior to admission. Hence, in MICUs of tertiary care hospital, where cases are typically received from various nearby SNCUs after receiving antibiotics, sepsis skin may not prove to be a very sensitive tool for deciding to when to start antimicrobial therapy. The present study shows Klebsiella, Citrobacter, and Staphylococcus as the commonest organisms. In Poonam Marwa et al., it is Staphylococcus, Klebsiella, and Acinetobacter. In Meenakshi Bhatt et al., it was Klebsiella, Staphylococcus, and E. coli. In Grishali, Avinash Mule et al., it was Klebsiella, Staphylococcus, and E. coli. Limitations of the study. The study is limited to only 6 months time period, and hence results obtained cannot be generalized to all the cases received throughout the entire year by the MICU at MGM. The study did not exclude the cases which went lama, absconded, or referred to higher centers, so the actual outcome of these cases could not be assessed. Concluding this session, the study emphasizes the importance of clinical suspicion of sepsis and starting antibiotics at the earliest for a better outcome. The present MICU unit policy at MGM Hospital Warangal appropriately covers the organism which caused pulmonary sepsis cases admitted under the institute. The incidence of complications are significant in culture positive cases and needs to be monitored for. Special thanks to Dr. G. Vijay Kumar sir, Dr. G. Pratap sir, and Dr. G. Karnakar sir. These are my references.
Yes, you finished in 7 minutes. And over to the jury for questions.
You have classified the children into different gestational ages, isn't it? So if you know the definition of term baby, what is the definition of term baby?
Any baby born between 37 weeks to 42 weeks of gestation.
Why 37 to 41 completed weeks. And 37 to 41 completed weeks. Then why did you divide those groups into three? I mean that group into three divisions. The definition is not what you said. The definition of term baby is that in this age group, the mortality and morbidity are same, whether you are born at 37 weeks or 41 weeks or 38 weeks or 39 weeks, the mortality and morbidity are same. Therefore, the scientists, obstetrician, pediatrician have chosen this age group as term baby. So why did you divide that into three divisions? Doesn't make sense. You got my point?
Yes, sir.
So remember the definition of term baby. It is the age in which the mortality and morbidity are same. After 41 weeks, that is 41 weeks and 6 days, that is 42 weeks onward, it is the placental insufficiency that causes morbidity and mortality. And before 37 weeks, it is the immaturity of the organs. I'm very sure you know that lung is the commonest. So dividing that group into three divisions doesn't make sense to me. Okay. Then your pattern, you said limitation, so that question is now out of thing because most of sepsis, there will be more cases of sepsis in rainy seasons, and your
Yes, sir.
doesn't include the rainy season.
Yes,
so
sir.
I am not going to ask question on that because you have mentioned that as a limitation point.
Yes, sir.
Now, a CRP in unit means sepsis unless proved otherwise. You have taken only culture as the criteria for sepsis, isn't it?
Yes, sir.
To include in your study. Well, that is your choice. But remember, CRP neonates means it is sepsis. CRP is a inflammatory marker. Yes. And the commonest inflammatory marker in newborns is
CRP.
sepsis only. So I don't know. You have children, so that's my point. The 2 points I just thought I'll let you know.
Thank you, sir. Thank you.
Dr. Waheed, what is the analysis method of analysis you have chosen?
Tableau software, sir. Basic analysis.
Say, the software is not analysis. Software is a medium. Say, if I say I have given to a patient tablets, it makes no sense. I should say ampicillin was given. It can be in the form of tablets, syrup, injection. So when you say statistical analysis, the method of statistical analysis you use it should be told. not what software you choose. Is
Okay,
that
sir.
clear?
Okay,
So that was one. Second, you said, in the limitations you said, since you have done the study for only 6 months periods, it may not be applicable for throughout the year. Do you think the organisms vary seasonally in newborns? Malaria varies,
Yes, sir.
isn't it? So it should be logical, isn't it? No? And that's fine. Then sepsis screen, what all you have done as a part of classical all sepsis screen? What were all done to screen sepsis?
In our setup, we do micro ESR and CRP, sir.
Those two cannot be simply called sepsis screen. Sepsis screen
Along
consists
with
of
hemogram, sir, which was having total leukocyte count and absolute neutrophil cell count.
say sepsis screen in neonatology has a very specific meaning. It has certain 5 components. If all 5 are done, you can say I have done sepsis screen. Doing CRP or CBP is not a sepsis screen. Okay, right? Good, thank you.
Thank you, sir.
Exactly, you did a good study for sepsis. What do you want to say to the audience? Your extra point in this. See, already known sepsis. So, what is your inference with this study? You want to say anything new to the audience? What is new you want to tell?
Basically, in my study, I wasn't expecting that result, but I have found that sepsis screen was not positive in all of the cases, which in our setup, the sepsis screen is done on the next day of admission, sir. So already by that time, if you have clinically suspected sepsis in that neonate, we would have already started antibiotics. And most of the cases received by MGM Hospital Varangal are coming from
So,
nearby districts.
anything new point you want to tell? See.
So I want to, basically I want, not just from my study, even I would like to further study the actual importance of sepsis screen in big tertiary care centers as a tool for starting antimicrobial therapy, because most of the cases which are received by bigger centers are after few days of antibiotic therapy, sometimes few weeks also, sir. So
Anyhow, by
in
the
how
time they
much,
come to you, they have been started with antibiotics, no?
yeah, so
So-
how, so we should do a multicentric study or something of,
At least for the community's sake, or for the house, you want to give any new point, because sepsis is a common thing everybody knows, right? Second
Yes, sir.
thing, you said respiratory distress is the most common when compared to other things.
Yes, sir.
Generally, sepsis means, as sir like rightly said, before 37 weeks, it is the respiratory. Otherwise, feeding difficulties, dullness, something like that. So, why only respiratory distress is more in your study, though it is term or preterm? Did you miss any preterm babies with HMDs, this and that, or congenital anomalies, or everything was said only sepsis? Because
no, sir,
sepsis is-
even cases of meconium aspiration, the reason for referral admission was documented, sir, not the symptom of
it is the
sepsis.
respiratory distress that is commonly seen in your
Yes, sir.
case,
In,
sepsis.
in preterms also and terms also, respiratory distress is there, sir. There were many cases of meconium aspiration, pneumonia.
That's the
also.
way the sepsis present. Usually, 77% of
No,
respiratory distress.
no, sir, no,
It's
sir.
not
In my
correct.
study, in the included samples, the maximum cases had the reason for referral as RD, sir. That is the only meaning of that analysis, sir.
So, sir wants to say something.
No question to you, but an observation I'll make. When you say meconium aspiration syndrome will cause a respiratory distress, do you mean that that is a case of sepsis? Or is it,
No, it's a case of meconium aspiration which showed culture positive with sepsis later on. Which showed a culture positivity later on. In-
Sir,
in-
some cases of meconium aspiration syndrome, in my setup, I do not give antibiotics to meconium aspiration syndrome at all.
Yes, sir.
In my setup, yeah,
sir.
there are times when you say, okay, I'll give prophylactic antibiotic, but in my setup, I do not give if it is meconium syndrome.
Yes, sir.
And at that point, the CRP may not be useful because CRP is just an inflammatory marker.
Marker.
Okay, this is just an inflammatory. And as you said, sepsis screen has got component of leukocytes. I mean, altered WBC count. It could be neutropenia, it could be neutrophilia, it could be leukopenia, it could be leukocytosis. And when I was a student, Buffy-Coat smear, we used to do culture,
sir.
even chest X-ray.
Yes, sir.
Everything included. So it's not just CRP or culture. Okay. And of course, when you say culture, culture should include urine culture.
Okay, sir.
All cases of sepsis should have urine culture done, and in specific time, 30% of the sepsis cases will have meningitis. You have done help in
Yes.
certain cases.
Yes, sir.
So that is the case-based decision.
Yes, sir.
So, but remember to do urine test, urine culture in all the cases, because this may be a hidden infection. Okay.
Yes,
I
sir.
think this is not a question to you, just some of my observations.
Thank you, sir. Thank you so much.
Thank you, sir. Thank you, Waheed. Next presenter is Nikhil. Nikhil, please come. See the presenters, the